channel again. Hello everyone, welcome back to my YouTube video channel. I am excited today to have a friend of mine, Dr. Charles Dewey, right? I've been working with him for a number of years with Rickard Lynn, and today I invite him to come to my show with Douglas. He's he's the company that he worked with is the Dagnat, and I want to ask Charles to give me some information about what you guys been up to with this company, and you were working with Douglas. Please welcome to my channel.
Thank you, Luck. Thanks for the introduction and the opportunity to share some of this information with our colleagues. And the future of dentistry is changing rapidly. One of the things we're seeing is an increase in the use of artificial intelligence. Artificial intelligence is definitely game-changing our ability to diagnose, our ability to increase treatment awareness, and as well as find things that we might not see ourselves with our own eyes. We might miss. We see with our own eyes and we hear with our own ears, but there's things that sometimes that are beyond us. And with technology, even artificial intelligence, artificial intelligence uses shades of gray, and you can actually see more points of gray than even the natural eye. So it has that ability as well. And so there's 2D and there's 3D. What we're talking about today is three-dimensional cone beam analysis with artificial intelligence. And very fortunate to be joined here with Doug. Dagnat is one of the only companies really that has been doing this. Not only have they been doing this for years. So this has been going on in Europe. Sometimes the United States is a little behind, right? So this has been going on for 3 years. Is it 3 years, Doug?
Yeah, 3.5 years. Yeah.
Yeah, and over 30 countries or something like that.
Yeah, over 30 countries now.
Over 30 countries have utilized this, and it's approved there. It's approved also in Canada, and we're working on the United States as well. But as I said, some things take a little longer in the United States. But the proof of concept has been done, and it's been very effective. And there's millions of data points that we have from years of information. And so it's my pleasure to introduce for a demo today to explore what the possibilities are for the future of dentistry when it pertains to artificial intelligence. And Doug is the countrywide manager for the Americas. We have one for Europe as well, but he's in charge of the Americas and Canada too as well, Doug, right?
Yeah, both? And Mexico. Yeah, US, Canada, and Mexico.
US, Canada, and Mexico.
We're expanding into South America as well too. We have a lot of demand from South America as well too. But of course, you got to get the regulatory first before you go ahead and have the product in the marketplace.
This is excited. I can't wait for Doug to share with us. Doug?
Yeah. So let me just quickly about Dagnat. The founder and CEO is Alex Sanders, he's got his PhD in prosthodontics and has worked with a large DSO in Europe, Eastern Europe, for quite a few years. He has his own practice. And 4 years ago, he felt like, you know what, CBCT is the way to go for diagnostics and all the data and analysis that's capable. But a few of the problems are, one, a lot of dentists in dental school, they're not trained how to read a CBCT. How they learn is through an implant course or through a manufacturer. And how good is that? We really don't know. It can vary. There's no standardization. So he felt like he saw the application of AI in 2D and X-rays and PANs, but also let's look at 3D as well too, CBCT, because that's where the dentists probably need the most help. So we did both. So we worked on 2D and 3D, and after 3.5 years now, we're quite expansive in over 30 countries. Thousands and thousands of customers. And also we have over 2 million teeth annotated. So I'm not going to get into the machine learning and that sort of stuff. Everyone's probably heard about artificial intelligence, what machine learning is. So obviously, the more information put into the machine learning, the smarter and the better and more accurate it gets. So we've annotated, meaning we've put through the machine learning over 2 million teeth with oral radiologists and general dentists and specialists to take a look and evaluate and make sure it's correct. So pretty exciting. We're getting to the point now where, you know, we're above 95%, 97 percentile in terms of accuracy, you know, with our studies and research and development, which is really exciting. So, you know, there's been many research done on dentists evaluating modalities on, you know, on an X-ray, and they miss about 30%. So that's the standard, what they're missing, just for different reasons. So, excuse me. So that's
this is incredible.
Yeah,
this is incredible. Excited.
And not only do they miss it, but you know, obviously, like caries, for example, there's going to be 100 different diagnoses by 100 different dentists. But you know, they just get focused, and all of a sudden a hygiene check, they get pulled away, and they're focused on the lower right quadrant where there's pain, but they don't even get to the upper left quadrant because they've been pulled away for a hygiene check. And meanwhile, there could be something serious going on in the upper left quadrant as well too.
Doug, can I interject for just one second? So, you know, what it does is it provides a level of objectivity as well, and a third person or an extra set of eyes to view things. Yeah, it also provides, you know, there's a certain legality that is involved and our legal liability that's involved, because with the transfer of data, you know, one dentist gets another cone beam from a patient that goes to another specialist, or perhaps a dentist transfers to another dental provider. They get a cone beam. Perhaps they don't have time to be reading it. They don't even know that they even have it. Maybe the office manager gets it on a disk or on a thumb drive, right? So, you know, when you transfer and you're sending it even to a specialist or a root canal specialist or oral surgeon, they're looking at tooth number 31. They're looking at one tooth. But the reality is that if they get that cone beam, they're responsible for the whole mouth, right? Yeah. But they may not have time necessarily to be doing the proper diagnosis. And without, like Doug said, general dentists are not properly trained on cone beams as of yet. Now, of course, as the new technology and the new schools come out, that's more of the curriculum. But as older guys, right, you have to update yourself and stay current and have the curriculum to be able to properly diagnose things. And yeah. It doesn't do a differential necessarily diagnosis on some pathology, but it will flag it. You know, so it will flag it out so that at least it's shown. And then that way you, as a general dentist, have the obligation or the ability to communicate with a radiologist or medical radiologist, oral or medical radiologist, to get the proper differential diagnosis and make sure that the patient does not, you know, have a pathology that is misdiagnosed or not kept for years on end. Yeah. So this is a huge, you know, legal liability thing too, as well.
Yeah. Charles, if we have time, I'll show a case of a rare pathology. So we do find rare pathology. So it's not on my one case, but I've got another one that I happen to be doing a segmentation with a doctor, and we ran a radiological report and found a rare pathology. So
fantastic.
Yeah. So it's
not good, but
not good for the patient, right? But yeah, it's a great screening tool for a general dentist or a specialist to, you know, see what's going on there, and then, you know, hey, it tells you to refer to an oral radiologist right away.
Can't wait, yeah. You guys.
So let me show you the software. It's a cloud-based software. Everything, you know, there's no downloading of the software. Pretty easy. You just go onto us.dagnacat.com. So let me pull that up. So let me go back to you know, the landing page here. So this is your landing page. Obviously, these are all the patients. us.dagnacat.com, and we can integrate it with your imaging software as well too. So when you go ahead and take a CBCT image, it'll pop up a box will ask, do you want to run a report, a Dagnat report? And you just click yes or no. So you can do that. So let me pull up my fictitious patient here. And this is the layout of you know, obviously the left side is the patient information. The doctors in the clinic are down here. And then there's a share feature, and I'll show you that after I show you the product, so you'll understand it a little bit better. But it's a great collaboration tool. I don't think anyone in the world has this capability. So,
and the
so then
the share feature is huge because Doug, you don't need to have a disk to wait to generate that. You don't need to send it via email or anything. I mean, you send it via email, it's automatically, right? So that's a huge advantageous aspect, look, to have the ability to share it.
Well, large, CBCT are large files, 250 to 600 megabytes, right? So it downloads, so they can be right in here and download it in 10, 15 seconds and have it on their computer. So real easy to do. And same with the STL viewer. So, well, let's go first and we'll, dental photos, you can upload dental photos for the patient and stuff like that to have on their file. We do FMX. So FMX is, everyone pretty much does these all the time. So you would hit order analysis. It takes about 2D is 5 to 6 seconds, and you'll have this analysis. And our layout is very similar right across the board for 2D and 3D. So you can see over here on the left, all the images, they're actually numbered for you as well too, and put in the right order. Then you can see the tooth chart. X is missing, red is unhealthy, purple is treated, and white is healthy. So let's go ahead and hit 14. And so you can see tooth 14. If I hover over the periodontal bone loss mild, right, there'll be a little green box and shows where the actual issue is, okay? So you got a pulp exposure, everything like that too. You can approve it. You can reset the tooth saying that you don't want it, that sort of thing as well too. This patient's got lots of work, say 14. I got to move our video box over here a little bit, but signs of caries, you just hover over it and you got the big green box where the caries is, okay? So then what we have down at the bottom is we have a Microsoft Word program. You can put in your notes, custom whatever you want for notes. You can actually have this as an official document and have the doctor sign it and print it. And then what's really nice is the print. So you can print this product, report for the patient. So you can either print it on paper and have it, this patient here would be terrified seeing all these green boxes around here and all the red. But you can remove that. You can, take the highlighted sections off, not to overwhelm them. And then you can download this as a PDF and email it to them or print it out and of course save it in their chart as well too.
Which is great for patient engagement.
Yeah, oh, for sure. Yeah, patient acceptance, is always a large, part of the practice, right? So
number one KPI that I would follow.
Yeah, exactly. So let's do a pan. So a pan is, again, I've got a few here, but we'll do this one here. So I go ahead and hit the radiological report for the pan. And again, the layout is very similar. So you got referral recommendations at the top for endodontist and for general practitioner. Let's go ahead and click on, say, 19. So you can sort of see here on 19, if I hover over periapical radiolucency, right? It's caught that. I can make this larger, of course, and then hover over it and it'll show it there for you, okay? And then same with short filling. It even tells that the endo was short. It didn't go all the way to the apex.
Yeah.
Lack of interproximal contact. Excuse me. So it's got all that, let's say 31, signs of caries. So you got caries on 31. And again, the same format, you can go ahead and print it out and send it to the patient. That's the 2D. So we do over 30 different, well over 30 modalities that we can do for the patient. Obviously all the main ones. So let's go back to CBCT. Now the excitement starts. So the 3D is something, as you can imagine, the data and analysis is 1,000 times more, not only difficult. We have 43 programmers at Dagnat who've been working for 3.5 years on this. So this isn't, you know, two programmers having an idea and going. We've put some major resources and people into this.
Mhm.
And so one thing that Dagnat's done that's really amazing, it's a patent. And what it is we reformat the CBCT into a PAN format just to be able to view it and diagnose from this, right? So the doctor can take a look at and diagnose.
Mhm.
So what I'm going to do here is I'll show you the order analysis. These are the different reports, the radiologic report, which you've seen before, but I'm going to go ahead and show it to you again. This is all in 3D. And this will take about 4 to 6 minutes to run because it's just so much data.
Mhm.
The 2D is 5 to 8 seconds and it's done. But the 3D is just so much more data, correct? Like you've got referral recommendations. It even does ortho screening. It'll talk about teeth crowding on, you know, 15 and 16 and 26 and 27, and, you know, some spacing at 4, that's 4.2 and 4.3. So overbite is increased and overjet is decreased. So let's click on say 14, and you can see the percentages here, what how confident the AI is that the filling is
notice
short.
it also tells you the canal percentage chance for 4 canals, like on an upper first molar, for example. So,
yeah,
you know how you know they can be between 4 to 5 canals, right? Or
right.
You know,
So there's 3 roots, but they're saying 4 canals. But again, this one it's only at 55%, which is not, you know, 65 and up is about pretty much the AI is going to probably be bang on. And of course, you know, it can be subjective. You know, short filling, one will say, no, that's not a short filling. Some will say it is. So, I mean, but the percentages can really, you know, give you an idea of where you want to be on your diagnosis. It's just an aid, right? And so you've got your slices here for say 14. You can click on 14 all slices and you'll get every slice in the CBCT for that tooth, right? Mm-hmm. So you've got it's all right there in front, and actually you can see some red. So it's picked up a little bit of periapical radiolucency here at the tip of this case.
And what I love is that you don't have to hover over the cone beam and kind of like try to navigate some of this, right? It's already automatically done.
Yeah.
Segmented.
Yeah.
That's incredible.
Yeah, and then another thing we have is the 3D viewer. So on your cone beam, you've got on your imaging center system, you've got the viewer, but here you can do it, you know, so say tooth 14 here, I've clicked on this, and since we're on a Zoom call, it'll take a second, but it usually jumps up right away, but I think the Zoom call slows it down a little bit. So it's nice having the 3D viewer, some call it an MPR, and you've got up here, you know, short filling, adequate, you know, endodontically treated tooth. So now you can just scroll through here and take a look at this one tooth in every axis, right?
So you have the ability to just scroll if you want, but it does the automatic segmentations. And the nice thing about the automatic segmentations is that it's automatically in these pieces. So you might scroll and inadvertently, as you're scrolling, you might miss something. So the fact that you have the automatic segmentations means you're going to see all these little glimpses, right? Yeah. So you're going to be able to really catch everything in full spectrum.
Yeah, it's just making you more efficient as a clinician, right? That's the whole goal is, you know, Alex's mission, our Dagnat's mission is we're trying to make dentistry as error-free as possible. You know, that's our mission statement. And really that's what we want to do is, you know, we'd love to get 100%, but obviously that's not going to happen. But, you know, if we can get, you know, less errors in dentistry, that would be great. It's a tough enough profession as it is. So that's the radiologic, and of course you can print it out and send. It's a little more detailed. You have the option of, you know, going ahead and you can show all the slices. You know, the orthodontic screening. You know, skeletal discrepancies. There's none in this case, but there can be. You know, you can have it as detailed as you want. Okay, so again, very easy to present to the patient.
And one thing, look, I think you can appreciate that because you and I have both worked on software together, is the user interface. Look how simple, and how user friendly the user interface is.
It is. It's very, very easy to use. So then let's get into the segmentation. So I want to sort of just preface, a lot of people aren't very familiar with true bone segmentation. They're not familiar with it. Their lab technician does it, or if they've never done a bone level surgical guide, like if they're going to do an all-in-4 and you're going to do a bone level surgical guide, you have to do the bone segmentation or that surgical guide will not fit. And so either the lab technician might know how to do it or the doctor has to do it. And so I want to sort of show what we do. So with the segmentation, it's fantastic. So we'll use this patient right here. And it's not a big implant patient, but still. So you would hit STL, and this is taking it from DICOM to STL. And then what it's doing is we're going to click the middle one, which is all the individual anatomy files. So there's going to be a separate file for the nerve, a separate file for the mandible, separate file for the maxilla, every tooth, the airway, the cranium, everything's separate. And this takes about 4 to 6 minutes compared to manually, this would take you an hour and a half. Okay. So here, and this is great for patient education. So in 6 minutes, you've got this in front of the patient. This is the actual patient 6 minutes later. And here we go. Like I've been playing with this a little bit, but let's put the soft tissue up. So we've segmented the soft tissue, right? So you can show the patient, their profile. For designing the implant case, if you have a large field of view, you can, design the case. You don't need a facial scanner. This is more accurate. You can use the outside of the nose and the pupils and everything else and design the whole case, smile design and everything. So let's take the soft tissue off. These numbers here represent the opacity, right? So like the maxilla, for example, you want to show the sinus, you just go ahead and say 35%. And you can show, everything where the sinus is and all the roots. You can look at all the roots. This is fantastic for ortho, of course, and of course for implants as well, too. So, you can zoom in, you can virtually extract. Let's say you're showing a patient, let's say we're going to extract tooth 29, right? Show the patient, then you go ahead and the mandible will put it at 100 so they can understand a little better. And, now they can sort of see there's a nerve there that they've got to make sure there's enough room to place the implant. So really good learning tool for the patient as well, too, in terms of, because it's in 3D, they understand that. Then
so
course,
can I ask you, so the color is come from the software?
Yeah, you can change it to whatever color you want.
Okay.
So you can literally do custom colors. You can do crazy colors if you want, right?
Got it.
And oh, that's the soft tissue. Sorry, yeah, you can change. You can do every tooth a different color, right? You can, make it stand out, sort of show the patient. So. Yeah, and then the airway, this one didn't show up very good because of the size of the field of view. But if you've got a larger one and you get the airway, you got the cranium, everything else as well too. So, and then the exciting part for, simplicity is you're down here. This is the STL that we did. You literally just hit download and I can, hit it in 10 seconds here. It'll be downloaded and every file is named, maxilla, mandible, and each tooth number. It's all done for you. So when you upload to your implant planning software or your ortho, excuse me, the ortho software, I don't know why, let's see here, I had to double click. So
it's download.
Yeah, so this is downloading onto my computer. So something that takes an hour and a half just took 6 minutes and then 10 seconds to download. And I open up the files and you can sort of see here all the files. They've got the name. Oh, sorry about that. So you can see all the teeth are individually done. So you can upload all the files or just the mandible or just the maxilla if you're extracting all the teeth. So
Doug, can you explain to people the differentiation between manual correlation of this stuff versus digital segmentation and the accuracy of surgical guides?
Yeah, so really what happens, let's go ahead and go back to the STL here. So what happens is when DICOM is transferred to STL, it doesn't go perfectly aligned. It's goes off a little bit. And so what happens is the bone is not, sometimes it grabs it as bone and sometimes it's not bone. And so what happens is you go ahead and you create a surgical guide, a bone level surgical guide, and there's bone there when it showed that there's not, and vice versa. And what happens is the guide, starts wobbling and stuff, and it's totally out of whack and doesn't fit. And they don't know who to blame. They don't know what the cause was. 90% of the time, it's the segmentation wasn't done correctly, either manually or it just wasn't done at all. Okay, so with us, the accuracy so far, we're finding 97 out of 100 are being done, and this is with CBCTs with lots of noise, lots of artifacts, lots of metal in the mouth. We did one with a metal in the lingual plate of the denture that they took a CBCT, and it worked. I mean, it's not going to be 100 out of 100, but it's pretty darn good, which is fantastic as well too. And yeah, so, and another thing too is Corey Glenn, actually, what he does is he has the patient bite down on the bite plate and smile. Because if you're taking the soft tissue and we can segment the soft tissue, that's how he can actually do a full mouth rehab that way without using facial scanners now. Okay. So so that's the product. Like, let me show you just quickly.
Can you show the endodontic section, please, too? Yeah.
Okay, sure. Let me just quickly show this one here, just really quickly. I was doing a segmentation on this patient, and I did a radiological report while I was waiting for the segmentation, and this is the rare pathology. So what it does is, you can't even really do anything. It just has this big red box around it with the green box around the rare pathology, and tells you to refer to an oral radiologist. So it's a great screening tool for the patient, for the doctors, right?
Yep.
So really good. So let me show you back. Excuse me, the other reports. The Endo Study. So I've selected 212. I mean, there's already a root canal here, but you can, you do it with or without. And what it does all the slices on there, and it gives angles and stuff. You can tell the angles of how difficult the canals are going to be. So it's a good screening tool for a general dentist. See how tough it is.
What about the automatic measuring of the length as well?
Yeah, so that's the implant. Now that one we haven't got approval yet. Of course, we haven't got FDA approval for anything yet. But yeah, so we've added this study as well too, and we've got to get approval for it, FDA approval. But it's great for an implant study. So this patient, obviously, you talked to them about a single tooth implant in that missing space. So from 28 to 32, I ran a report, and it's got all the measuring tool in this area. And, so you can click and you can click on here, and you got the nerve populated, and you can measure from there to the crest of the bone and see if there's needed bone grafting or not. So it's a great tool to have in front of your patient. You're talking about an implant case, and you can measure the width, of course, as well too, at whatever points you need to be at. And you can get a 3.5 in there at least, and stuff like that. And so you're not going back and asking for bone grafting fee as well too, or a sinus lift fee. So at least you can talk to the patient right away about that. So they have those tools available in the implant planning software, but at least, you've got it while the patient's still in the chair and you're talking to them.
Doug, at one point in time, you showed me the endodontic section where it actually measures the root lengths, and it actually gives those root lengths
yeah, that I don't have available. That's in development stage. Yeah, that's in our development phase. We actually segment the roots, complete roots, even lateral canals. Really amazing stuff. So that's still in development phase. We have a very strict process. It goes to dental clinics, and specialists evaluate it and stuff like that. So real exciting stuff. And along with that comes the 3D mapping of the periapical lesion as well too. As you can see, let me move out of the way there. You can see that right there. That's what the purple one is. You've got the red periapical lesions in 3D showing the patient, because grayscale patients don't understand it. But you show them a 3D at the tip of the root of a lesion that's eating away the tooth. What's that?
Or impactions, right? Like
Yeah.
ortho impactions, you could see
exactly.
the eruption of the
Ortho
teeth
impactions, supernumerary teeth, stuff like that. They can visualize a 3D image a lot better than they can a 2D, right?
Development of a wisdom tooth, right?
Yeah, so like the third molar study is again very similar to the endo. You would select a tooth. This one doesn't have an impacted tooth, which I got to get one. But it takes the canal, shows you that, and slices. And of course, this one's not as difficult as some of the others would be, but gives you an idea really quickly what you're looking at. And your assistant can run these reports before the doctor's even in the chair if you want. So let's show you the collaboration tool now. Now that it makes sense. So we've got the doctors here, but we also have a share feature. So which is fabulous is, as you know, 3D files are very large, clunky. Do you have an STL viewer or software to view it? A lot don't, or they don't know what software to use. So all you have to do is, let's say you're a specialist or a clinician and you want to share it with another specialist or a GP or a lab technician. You hit share and you put in their email address and send an invite to them. And so they can come into Dagnat. They do not have to have a Dagnat subscription or anything like that. And they can come in and see this one patient, Andrew Chan, and they can go ahead and see everything and do everything that I showed you, including downloading in 20 seconds that file, right? You just hit download and away you go. And you've downloaded onto your computer, uploaded to your implant planning software. And so now in 40 seconds, you've got your large file into your implant planning software or ortho planning software or whatever you're doing. So real slick and easy to share, and it's HIPAA compliant. So makes things proper. Whereas WeTransfer, you're not really supposed to be doing that unless you get the medical license, say with Dropbox. So.
How about the orthodontic advantageous aspects that you've seen, Doug, as far as utilization of that, and perhaps even self-tracing, automatic analysis, and so forth with points of reference?
Right, the Ortho Report, I'll show it to you. We are relaunching it. We launched it for a little while in Europe, and the orthodontists wanted more points. So for self-tracing, so really, self-tracing will be obsolete, almost is now, but will totally be obsolete because we're going to have over 60 points, key points. Again, it's reformatted for a PAN format. And then we do the left and right and frontal self-tracing. There's going to be 60 points with the angles because we just had like 12 before and they wanted more key points. Then you've got your cross-sectional images on your teeth. Then you have your coronal images on the teeth, TMJ sagittal slices. This is all done in 4 minutes, right? So your TMJ coronal slices, TMJ coronal summation, which real important, and sagittal summation, and then the airway as well too. So the airway is, excuse me, the narrowest spot. They give you the measurement and it goes red, so to show the patient. So.
Well, that's an advantageous aspect too as well, because now we know that we're also not just straightening the teeth out, right? We're also considering the airway, right? The air trumps everything, right? So if you don't breathe, you don't live, right? So yeah. now we know that it's the importance of that. And so every orthodontist is now obviously aware of that. They're considering the airway in their treatment planning. Right. And sleep apnea is a huge thing as well, right? Even
absolutely.
Children and focus and the ability to do well in school and everything else. And so this is huge.
Because now you can go back, you show the patient this, and especially if they have all the indicators of obstructive sleep apnea, they tick off all the boxes. then you can go back to the STL viewer and, take the mandible and the maxilla and the teeth out of the way and just show them the airway and show them, look at, it's, first of all, everyone thinks their airway is round, and it's not. It's just shaped like that, right? So they go ahead and can see that, and maybe they'll take their potential OSA more serious, which is important, right? That's one of the problems, is they don't take it serious enough. So,
and and when it comes to treatment planning for surgical cases like Lafort surgery and things of that nature, right? It is very important to be able to properly diagnose apnea. And you don't want to retract the mandible in a situation where you already have an airway that's not
exactly
adequate, right?
Exactly, yeah. So
yeah,
it all ties together, and it just makes digital dentistry so much faster and easier and more efficient, right? That's the idea. So let me quickly show you something that's coming down the pipe very, very soon, and real excited. I'm excited about this one. I think I had a conversation with Charles earlier about this. So we call it 3D fusion. And, so one of the issues is of course, in digital dentistry, the process can be very tedious and time consuming. So let's take our artificial intelligence and we take the intraoral scan. Obviously, I just showed you the segmentation of the CBCT. So now we segment every single tooth in the iOS and the gingiva. So now the gingiva is segmented as well, right? Then what we do is we superimposition, so meaning we align the iOS with the CBCT, but we take it a step further, and we know the roots of the CBCT are very, very accurate in correlation and imposition, and we take the coronal aspect of the iOS and we merge the two together. So now you have a very accurate digital representation. And it's very, very hard to be out of line. And so, here's a case here. Let's say you got a fractured lateral. Think about this now in terms of your planning of an implant case. You've got a fractured lateral. You can virtually extract it. You can design the crown first. So crown down design. You design the crown perfectly because you got the gingiva there as well too. And you design the crown, then you design the abutment, and then you rotate around in 3D and place the implant, and you can see in 3D if the implant's going to fit in the bone, which, you can also do that in the 2D viewer as well. But now you've got really the best way to design an implant case. And of course, for ortho, this it parallels ortho as well too, right? So really, so now you can do a tooth level surgical guide and it's accurate, or a bone level surgical guide and it's accurate. Okay.
And look, I mean, you can appreciate this as a general dentist. Of course, sometimes as specialists, you get the case back and they have to place the implant where the bone is because that's where they have to place it. And then we're left with the restorative nightmare afterwards, right?
Yeah.
So, now I know with, digital dentistry and CEREC, you can treatment plan the coronal aspect, try to get the implant to place in the proper location to fit that coronal restoration. So you're not having an overhanging restoration. You're not having a TP'd reservation, so now you have a big undercut underneath it there, or maybe it's hard to get the good close of embrasures space because of inadequate placement, right? And depth and everything else, right? So with this soft tissue ability to have the soft tissue merging with this hard tissue and all this, I think it just adds one more new level, like another level of sophistication of what we're going to be able to do, right?
Right. Not only time, this isn't all of course, it's time saving. We're talking probably an hour and a half to 2 hours of a technician's time, but it's also turnaround time faster now. So, it's not going to, it doesn't take weeks, right? You can get this sort of done quickly if your patient wants it and the doctor wants it. So,
and ultimately better clinical success,
yeah,
right? And patient outcome.
Absolutely, for sure. So, I mean, less room for error, right? I mean, we don't say we're more accurate than a technician, but we're more consistent, right? I mean, AI doesn't have a bad day or, is tired, right? So, and that's the same with diagnostics as well, too. So, at the end of the day, a dentist is tired looking at x-rays all day, right? Their eyes are tired. It is what it is. So,
you're doing a long 4-hour sedation case with oral sedation, or you're coming out of a pedo case that's not going so well, or you're going,
yeah,
you got the other extra oral demands that are going on in the office of a server going down or computers. So, dentists, we're the jack of all trades. We have multiple hats that we wear.
Yeah.
So it is nice to release one of the hats, right? And to have at least an extra set of eyes that are there to, make sure that we're doing the proper treatment, the proper, diagnosis, the proper treatment planning, or maybe even another opinion. Dentists are usually on a lonely island by themselves, no one to talk with, right? That's one of the advantages. I had a fee-for-service office for over 20 years, and I had a partner. And the one thing was nice is that we could sit next to each other and we could go back and forth. Hey, take a look at this case. During the day, look, you're practiced by yourself, is it correct? So, sometimes you don't have that ability for a real-time secondary consultation ability.
Yeah.
Yep. So,
Is that a fair statement, Look, or what do you think?
Hey, definitely. Sorry, I was put on mute, so that's why you guys didn't hear me. I think it's beautiful. This is something incredible. My hope is that can you imagine that every office have this tool, and the artificial intelligence system that you guys have, it just would change the world of how we practice for sure. And I wonder if let's say with this software, maybe all of the software that we have right now with different imaging company out there, if they all use oh my God.
Right. Yeah, it would make sense, wouldn't it? The other thing I'm showing right here is our business analytics, and this is for like group practices and DSOs. Can you imagine right now, as a manager, being able to find out every office, every procedure, by every modality, by every doctor, by any day, any day, week, month, year, and that's what's loading right now. So now, of course, this is just this one office, but you would be able to, do this for all your 25, 50, 100 offices, and have all the pathology, all the caries, all the missing non-restorable teeth, all the endo problems, perio problem by doctor, right? By referral, by study type,
well,
PANS, CTs. So
what that does is that allows for the ability for practice evaluation when you're buying a practice, or you're doing that too as well. So you get to know kind of the health of the practice and what's available and what's being diagnosed and what's not being diagnosed, and it does have an accountability aspect as well, right?
Yeah, I mean,
or
something
to achieve, right? You want to achieve.
Can you imagine? Health. I mean, chart audits right now, DSOs are spending a month doing a chart audit. You can do a chart audit in 10 minutes, right? With this. So if the office is using AI in their office, right? So I think that's super exciting for the large group practices and any more than two, right? 2, 3 offices. It's a great tool to have at your fingertips by clicking a few buttons. So
I was talking to a friend of mine. He's the optometrist, and we were talking artificial intelligence during lunch today. And now it's all about artificial intelligence for dentistry and medicine, optometrists.
Yeah.
The world have rapidly changed, and I look, maybe during my son generation, by the time he graduates, the stuff that I've been using and doing in dentistry, probably he cannot use it because he's gonna use what you guys have right now.
Yeah, exactly. I mean,
well,
yeah.
Think about in medicine, alone, right? Let's say medicine or dentistry too. Let's say you have a pathology, right? And you have 2 medical doctors, and you're in surgery, and you're in the middle of the thick of it, and you're doing a real-time sample of pathology, and they disagree. One says, no, it's not cancer. The other says, yes, it is cancer. What do you do with that? When you have 2 pathologists that are on opposite sides of the spectrum of what to do, and they're trying to do a clinical outcome in real time on a patient, are you going to put the patient back together and say, let's come back and reevaluate this later? Or is it possible that you can have a third person, or AI, artificial intelligence, that has millions of data sets that will say, you know what, the probability that this is cancer based on these data sets from other practitioners of millions of evaluations has come to this conclusion? I think it's nice to have that independent third-party evaluation. And it is being used in medicine today, and it's going to be used in dentistry as well.
Oh,
And
absolutely.
know.
Charles, I don't know if you know this, but I was involved. I started Protosite AI in Toronto. It's a startup in Toronto. They're going to probably launch in the next 6 months. Dr. Anthony Morlance, the chief clinical officer for the company. And what it does is it takes AI. So you take a biopsy, a tissue biopsy. And of course, squamous cell carcinoma is real easy to find. That's easy for a oral pathologist. But dysplasia, precancerous, is tough. Is it mild, moderate, or severe? And they've been using the same clinical system since 1982, I believe it is. So we take the AI, put the AI towards it, along with some genetic biomarkers, and it can tell if that dysplasia is going to turn into oral cancer in the next 5 years. Mm-hmm. And there's nothing like it in the world, and they've been working on it for 8 years at the Mars building in Toronto, downtown Toronto, and fascinating stuff. And it should be available to especially oral surgeons. In 2019, there was 600,000 oral biopsies by oral surgeons. Wow. So you can imagine, how many of those were dysplasia that turned into oral cancer. And the test results are, the success rate is super high. Sensitivity and specificity is up in the high 90s. So it's fabulous. It's just a new tool.
That's what I like about that endo portion, where it shows you the percentage of probability of a fourth canal. I mean, right. How many guys are general dentists that are doing root canals on upper first molars that are no, there's not a second canal. When the reality is that there is probably a second canal there. And then later that patient deals with infections and sinus infections that go, you've probably seen that look before. I don't know if you've had that experience, but I've had patients that have had ongoing sinus infections and surgeries for years because of missed secondary canals or missed canals and root canal systems that were never properly diagnosed. The other thing is that, even those secondary canals, sometimes they're so nebulous and so hard to find that the endodontist, in the process of finding it, they find it, but they're like troughing and digging and opening up that root structure so much to get to even the canal that they jeopardize the tooth. And the problem, I've gotten them back before, and not to the fault of endodontists. I think endodontists are fantastic, right? But you've had that before, right? Every once in a while you'll find one, and you'll be like, wow, why did you dig so much? Look at that root structure in that for finding that one canal. And occasionally you'll even find a little bit of white MTA. You'll find a little, oh, did you perf there? And that, oh yeah, I did perf in there. Well, you didn't tell me that. I just saw the MTA that was white that was in there, but that's not the majority. I'm just saying that it does happen. Nobody's perfect, even specialists, right? Yeah. And so this ability to diagnose things in a three-dimensional ability, right, is way more sophisticated than not. It's kind of like cleaning canals out three-dimensionally with irrigation, right?
Right.
So there's just this a higher. I believe this look. I believe that at some point in time that this will be considered the standard of care.
Oh yeah.
I think right now it elevates the standard of care.
No, right now I believe this is something that we should start having all the dental school, all the dental educational institution to apply this technology right away. Yeah, and it's important. It's just a higher standard of care for sure. Right. And and that's after that. Once the kid learn how to use this technology in school, they most likely is gonna implement in their practice, because they can't without it. They cannot be comfortable. They have the
Exactly.
Part of the problem with an educational institution is you can only teach so much in so much time, right? So they try to make safe, proficient starters. But the problem is that the reality is that the dental anatomy, the world, everything that we do, it's variable, right? Every morphology of a tooth is different. Every canal is different. Every patient's different, right? Their medical complexities, everything. So this is an amazing training ability to train dentists on different scenarios. Matter of fact, in the future, we will see virtual training. I know this. We're going to see virtual training with simulators. okay, to do treatment planning 3-dimensionally and treatment cases 3-dimensionally, okay, without the actual physical patient there. So you'll be able to do, you'll be able to do cases that are going to be 3-dimensional and train, and then you'll be able to increase your speed and your efficiency based on cases that are not typodonts, that are standard typodonts. They will be, will be real-time things here. So the future is incredible for what is possible from an educational standpoint, from a treatment standpoint, and a clinical success standpoint by using this technology.
So much, you guys. Thank you so much. Imagine this: you have a center. You walk. You don't. You just make an app appointment. You go there. You get an X-ray taken by a robot, a robotic machine, and it one click. They send it to a center somewhere, diagnosis for you, and you can exactly what you need to get done.
Yeah. Yeah,
I mean, it might even be treatment planning. It might even generate automatic treatment planning.
Yes, exactly.
Because right? I mean, that's variable by everybody's experience. How much experience have you had after dental school? Did you go to Spears? Did you go to Pankey? Did you go to whatever additional did you do? Both of us, we both did an advanced educational dental dentistry residency program, right?
Mm-hmm.
That was an invaluable experience, correct? I mean, you learned a lot, in that one year doing hospital cases and doing working in hand in hand more individually with specialists, right? So
absolutely. Gentlemen, thank you so much for the invitation that you bring me to this presentation that you have. I love it. I look forward to get update, and if anybody listen to us or watching us, how do they contact one of you guys?
Yeah, just the best way to get a hold of us is Dagnat.com. So www.dagnat.com, or you can email me directly at Doug@dagnat.com. So real easy, and we have an 800 number right on the website as well too, so you can get a hold of us that way. So yeah, anytime, and I can do a Zoom call and do a demonstration to the whole team and show them all what all the AI does for them. So
I'm super excited. I can't wait to come back to you guys, bring you back, have more conversation about the latest technology that you guys provide for this dental community. Thank you, you guys.
Okay,
Charles, thank you, Doug.
Appreciate the opportunity. Always a pleasure. Okay.
Okay,
See you guys next time. Share to Google.